lactating mothers may begin ovulation return 3 to 6 months. Now remember, it's not a good form of contraception. People believe that breastfeeding is a good contraceptive, but it's not. So the non-lactating, sometimes it's 6 to 10 weeks after birth before ovulation returns. And sexual activity, I've got here, ain't nobody got time for that, right? You've got a baby, you've got sleep deprivation, vaginal dryness, lack of time together may impact time together may, well, I'll say that twice, lack of time together may impact resumption of sexual activity. So usually sexual intercourse is resumed once the episiotomy has healed and lochia has stopped, usually about 6 weeks. They usually say nothing in the vagina for 6 weeks. Breastfeeding mother may have leakage of milk from nipples with sexual arousal, which is pretty normal. And this is a good part. So contraception, this is something they need to be thinking about, right? That should be part of the discharge planning is, what's your plan? Contraception. You don't want to, at your 6-week follow-up, find out you're pregnant, so, lactation is not contraception. You can refer, I think, I've got the chapter, that's not the right chapter, never mind. Look in your textbook for any contraceptive information in your chapters. So discharge and teaching includes conversations about birth control to get them thinking about what route is going to be best for them. They do have options. Talk about the advantages and disadvantages with them, any risk factors, any contraindications. Breastfeeding mothers concerned that contraceptive methods will interfere with the ability to breastfeed. And then you tell them their available options. Do that for Justin only. So when we're preparing our clients for discharge, discharge teaching starts on the first day of admission. When you get them in the hospital, that's when you start doing discharge teaching. You're preparing them to be ready to go within 24 to 48 hours. So you have to start teaching right away. So the nurse is continually assessing the mother's needs and knowledge. So whether they deliver vaginally or by C-section, discharge preparation should begin when expected mother enters birthing unit. As I said, we teach from the moment we come into contact with our patients through the stay, discharge, and sometimes beyond. If they're coming back for lactation consultants, if they're calling on the phone saying, this is going on with my infant, it will show or whatever, we're still teaching, we're still telling them what to do. So, we're going to encourage them to write down any questions for the doctor. Write down all your questions. You get home and you have questions, and when you get to your baby's first visit, you forget everything you wanted to ask. Well, write those things down so that you remember. Because, we're tired, they're sleep deprived, they're taking care of a screaming baby, whatever. They're not going to remember everything they want to ask. And then when they leave, they're like, oh, crap, I forgot to ask about this, about the baby's cord or whatever. So tell them to write it down. Of course, nurses should be available to answer questions and provide support to parents. Make sure you confirm if the parents have any last-minute questions before they leave. Any other questions for me before you leave? Once they leave, you're available by phone, but you're not going to go to their house and show them how to do cord care or circumcision care or whatever. So. And if it is a case where they can't do it, maybe they need some home health checking on them or something, or social services. If there's things that they don't quite comprehend, and you don't feel comfortable, with their kid, maybe you need to get somebody else involved. So. Oxygen needs. This is our last lecture. And I've got chapter 18. So, when we talk about our oxygen need, we're going to go back to that postpartum hemorrhage. So postpartum hemorrhage is a leading cause of maternal morbidity and mortality in the United States and worldwide. The greatest likelihood for occurrence is within the first 4 postpartum hours. So it's a loss of more than 500 ml of blood after vaginal and 1,000 after cesarean. So during this time, the blood flow to the uterus is between 500 and 800 ml per minute. The blood's flowing at 500 to 800 ml per minute with that placental site and everything, so you can see why there's increased risk for hemorrhage. So early acute or primary postpartum hemorrhage occurs within 24 hours and can occur up to 6 to 12 weeks postpartum. I've seen women come back in after being home for a couple of weeks and have postpartum hemorrhage. So as we talked about, it could occur later. So we teach our patients. Remember, the placental site contains multiple exposed venous areas. If it doesn't heal over well, it can continue to bleed. So uterine apnea is also the #1 cause of postpartum hemorrhage. So failure of that uterus to contract down and shrink back down is the #1 cause of hemorrhage. So for some reason, it's not doing what it's supposed to. They may have infection, they may have endometritis, there may be retained placental fragments, whatever. We've got to remedy that quickly. Somebody look at chapter 18, page 495.
Okay.
Am I on track? Mm-hmm. So chapter 18, page 495. Okay, cool. All right, so what's some risk factors for postpartum hemorrhage occurring? So if we know our risk factors, we can watch our patients even closer, right? So, the overdistension of the uterus, we talked about this already, but from the polyhydramnios, that the uterus got stretched to its limits. A large baby or multiple gestation, anything that stretches that uterus to the max can cause postpartum hemorrhage. Multiple pregnancies, older uteruses will have poor muscle tone. Any anesthetics can cause that. Especially, refer back to if they have general anesthetic, everything's put to sleep, right? So if the uterus is put to sleep and it doesn't wake up and do what it's supposed to, then we've got postpartum hemorrhage. So any anesthetics that relax the uterus. Any trauma, they could have used forceps or intrauterine manipulation. They could use forceps to try to rotate the head and pull the baby out. That can cause lacerations. That can cause hemorrhage. The trauma to the vaginal tract. Soft tissue trauma from prolonged or rapid labor. So either a rapid labor or a prolonged labor can cause trauma to the tissues. The baby comes out too fast, or if it stays there and stays there and stays there too long, we can have trauma to that area. If we think about a prolonged labor, so the uterus is prolonged, contracting for a long period of time, maybe not as effective, so it's taking longer. So that uterus gets tired, right, after that prolonged labor. It's not going to contract like we want it to in the postpartum period to prevent that hemorrhage. So these are all risk factors that we need to take into consideration and say, okay, she had a really long labor, so she's going to be at a higher risk for postpartum hemorrhage. So I'm going to really have to diligently go in there every 10 minutes, every 15 minutes, or whatever, and check on this patient, because she's at increased risk. Or she's had multiple babies, or she had a postpartum hemorrhage prior. I got to really be on my game. So, not that we aren't anyway, but this puts us on high alert, right? We know. I got a heads up. Remember that retained placental tissue. It's pretty common to cause that. So what's our nursing plan? So we must monitor and assess our uterine tone and our locative flow. Again, use your eyes and your hands. Don't rely on the vital signs to tell you that your patient is bleeding too much. By that time, it could be too late. The change in blood pressure pulse may not be seen until there has been a significant blood loss, because women start with a higher blood volume from pregnancy. At BASS, we've seen most of us have seen their hemorrhage cart. Some of us maybe haven't seen it yet, but they do have a hemorrhage cart. It has a scale to weigh pads, so it tells you on the cart what the pads weigh dry. So then you can tell, you subtract, and how much blood loss there is, because 1 milliliter of blood equals 1 gram. That's how they determine blood loss. 1 milliliter of blood equals 1 gram. They also, on the cart, they have tools to scrape placental fragments. They have a uterine balloon that they can put in there and inflate to put pressure on that placental attachment site where the bleeding's occurring. They can leave that in for a little bit, or they can use it temporarily before they can get into surgery and see what's going on. They have a blood warmer, you know, your stuff that you need to run blood in fast, and the blood warmer. Because what did I say, a woman can bleed out in like 8 minutes, 7 to 8 minutes or whatever, 6 to 8, so you gotta be booking it and getting everything you need, and having all your ducks in a row. That's why we have the cart, right? So, just like our crash cart in an emergency situation. Everything you need should be on that crash cart. Everything you need for postpartum hemorrhage should be on that cart. Except your medications, of course, but, you know, medications are usually pretty easily accessible, so make sure we're bolusing our pit and doing everything we need to do after delivery. It might be in your best interest during clinicals just to know where that cart is, just like to know where the crash cart is. If the nurse says, we need the hemorrhage cart right now, and you're standing there, you need to know where that hemorrhage cart is, right? So, at FAST right now, it's in where the peanut balls and the birthing balls are in that closet, so know where that's at and go get it and hurry. So as we said early, postpartum hemorrhage can occur in the first 24 hours after birth. Bleeding may be slow, heavy, or even massive. Now, if I talk about my patient that had retained placenta that I took care of years ago, you know, her bleeding was moderate, fundus was firm. 15 minutes later, you go in there and there's blood literally dripping onto the floor. It can occur that quickly, and she ended up having to go up for a DNC to get the retained placental fragment out. And they didn't know she had a retained placental fragment because assuming the doctor's looking at the placenta and making sure it looks like it's intact, right? So she had just if you have the tiniest little piece left in there, you're going to hemorrhage. So we did see the exception to this when we saw a lady that delivered very early, a very early baby who had retained placenta, but the doctor was sitting at the desk saying, well, but she's not hemorrhaging, so, and this is like 2 hours, you know. Usually after 30 minutes it's considered retained and they go in and do a DNC, right? This was like a couple hours or more, but she didn't die, so she evidently wasn't hemorrhaging very bad, but you know, granted too, she was at like 22 to 23 weeks gestation. Well, your placenta's not ready to come out then, right? It's not supposed to. It's supposed to last, you know, until, you know, 38 plus weeks or 38 to 42 or whatever. So it just wasn't ready. So, you know, then there again, it depends on the situation. Don't ever assume things, but close observation, hands-on, feeling the fundus, looking at what your, you know, bleeding is and all that. So, sometimes when you palpate the uterus, again, I said you would feel clots that need to be expressed, so you can kind of, as you're pushing on the fundus, those clots are coming out. That's good. We need those to be expressed, right? Of course, uterine can also be caused by trauma to the birth canal. Abnormalities can include inversion, and that's just basically where the uterus turns inside out. It inverts inside out. We don't want that to happen, right? When we're mashing on it, we don't want it to like flip around or come out, you know, so we have to be careful of that. And then we talked about the retained placenta, and then we also talked about disseminated intravascular coagulation, because that can go along with postpartum hemorrhage. I'll go back to the old days again. When we did frontal checks, we put our hand, our non-dominant hand, on the symphysis pubis at the base of the uterus and massaged the fundus with our dominant hand. So we kind of supported the bottom of the uterus a little bit. I don't know if they do that as much anymore, but that's the way I was taught. You support the bottom of the uterus and you massage the fundus at the top. So you just mash the. Yeah, you just do their mash, don't they? They gotta do. Yeah. So remember that placenta does not separate effectively and come out all in one piece, we're in trouble. If tissue's got to get out of it. And remember the signs of disseminated intravascular coagulation, widespread bleeding and clotting. There's all these things going on. You'll see the PPA, you might see bleeding from your IV site, your Foley, whatever. So, close observation. Bad news. You have to fix it quickly. So then our uterine atony, some of our predisposing and things we just talked about, is the uterus is overstretched, you're going to have some uterine atony, it's not going to clamp down right. That's what atony means, it's not toned. So failure of the uterus to contract, lack of muscle tone, leading cause of postpartum hemorrhage complicating 1 in 20 births. Blood may be flowing out of the uterus, but pooling inside the uterus. You may not see it coming out as much, it may be pooling. So uterine atony is defined as failure of the uterine myometrium to contract and retract following birth. Predisposing factors again. High parity, hygramnios, multi-fetal gestation, large fetuses, traumatic birth, the use of halogenated anesthesia that puts everything to sleep. Mag sulfate, what does mag sulfate do? It's a relaxant. Magnesium is calming, right? So we calmed everything down, but now we want that uterus to not be calm and to contract down and not hemorrhage. So there's a predisposing factor. So if your patient's on magnesium, you know they're at a higher risk for postpartum hemorrhage. Prolonged labor, augmenting the labor. We're using the pit, we're augmenting with the labor. So then after, it's going to be tougher to get it to contract down. So usually they'll bolus that pit at 999 to really get that uterus to contract down. Once the placenta delivers. Not before it delivers, but once it delivers. You know, sometimes if the placenta separates prematurely, it could cause some more trauma to that separation point. You know, the placenta previa, that's what we would be looking at. It could cause trauma to that separation point. Again, with our retained placenta. Sometimes it's caused by peeling off instead of waiting for it to separate naturally. The doctor's pulling, tugging. Well, we don't pull it out. We let it deliver. I mean, they can do gentle, manual pressure on the cord, but you don't want to be yanking on it. Make sure we check our placentas to see if they're intact. Look at the shiny side, we look at the mom's side, the maternal side is that rough side that's stuck to the uterus. If there's any chunks missing, we can see that and say, wait a minute, this doesn't look intact, we might have a problem. So, usually the provider's supposed to do that, you're supposed to check that placenta closely. And the nurse, it's your responsibility as a labor nurse as well to make sure that everything's right. So treatment we talked about could be manual extraction, DNC, or worst case scenario. What are they going to do? Hysterectomy. That's where I was almost at with my first child. With that placenta accreta. I got 3 units of blood. I was looking at a hysterectomy. 20 years old when I delivered. So that's pretty scary to think this may be the only child I have because I can't stop bleeding. Not to mention I bleed to death, but yeah. So important. Mashing on the fundus or bolusing pit bag after the placenta. So lacerations of the birth canal. Other predisposing factors we talked about, cervix, vagina, and perineum. You know, depending on the size and presentation of the infant, if they used forceps, there could be some trauma. We may be able to see it, we may not be able to see it. It may be up in there, so the doctor usually does a thorough check for any lacerations, skid marks, whatever, to make sure nothing's bleeding, nothing looks crazy. So. There's that EIC. So 213 to 214 is what I have on my slide. Hopefully that's close. Disinseminated a form of clotting that is diffuse. So a pathologic form of clotting is diffuse clotting, and it consumes large amounts of clotting factors. So that's going to cause widespread external bleeding, listing all those clotting factors, internal bleeding, or both, and clotting. So it's confusing, but just realize everything's jacked up. There's a bunch of clotting, the clotting factors aren't there to stop the bleeding where they need to, and you're going to see bleeding, okay? So it's triggered by the clotting cascade, so either extrinsically or by release of large amounts of tissue thromboplastin, you don't need to write this down, or intrinsically by widespread damage to vascular integrity. So it can be common with abruptio placenta, where the placenta prematurely separates before baby's born. A retained dead fetus can cause DIC, so if they don't deliver, if they have an intrauterine fetal death, and they don't deliver, that can put them at risk for DIC. Severe preeclampsia, HELLP syndrome, because with HELLP syndrome, what does that stand for? What's low with HELLP syndrome?
Platelets.
Enzymes and platelets.
Yeah, so your liver enzymes are high. So you have elevated liver enzymes, because remember, your liver has a lot to do with your clotting and all that, right? So your liver enzymes are elevated, but your platelets are low. So if your platelets are low, you have a more chance of hemorrhaging, right? So if they have HELLP syndrome, they're going to be at a high risk of going into disseminated vascular coagulation. So if we look at HELLP, it's hemolysis. The H is hemolysis, which is a breaking down of red blood cells, right? The EL is elevated liver enzymes, and the LP is low platelet count. You can also see DIC if they have gram-negative sepsis. If they're septic, they can go into DIC. So then our symptoms are excessive bleeding. It can be from the gums, nose, IV site, petechiae. Like I said, it could be around the blood pressure cuff, where it's causing pressure in the arm. You can see petechiae there. You might notice there may be some gastrointestinal bleeding. It can come from anywhere. You'll notice increased pulse and decreased blood pressure. Your patients can quickly become diaphoretic and may get that sense of impending doom. This is really serious. Our assessment skills must be keen when we're watching for this, especially if we know they're at a higher risk for it. So our platelets will be decreased, fibrinogen is decreased. They could have low hemoglobin and low hematocrit. And then they have an elevated fibrin split or degradation products. So don't worry about all that. But just realize DIC, widespread clotting, bleeding. What's your signs and symptoms? What do you do about it, okay? So we assess for bleeding, and we may administer volume replacement or blood products. We're going to watch for reactions to our blood, and that sets up a whole other animal, right? Then they can have a reaction to the blood, so we're watching for that. We want to optimize oxygenation and perfusion. We're going to protect our client from injury. If they have all these widespread bleeding, they could get injury, so we're going to have soft cushions on our bed rails as needed. We may be watching, or we will be watching our urinary output via Foley catheter. We need to know our output, and if there's blood in the urine, right? What better way to know that than to have Foley? They must maintain an output of 30 ml per hour. That's just common, right? We want our patients to have at least 30 ml per hour output. We may end up giving them vitamin K. So what does vitamin K do? Clot. K for clot, right? So vitamin K may be one of your treatments for this. We talk about late postpartum hemorrhage. So just later, not right after birth. So it It occur 1 to 2 weeks or even later after delivery. Also, that when I was talking about inversion of the uterus, if they pull on the umbilical cord to try to get the placenta delivered, and the placenta is still attached, they can cause the uterus to invert. So it can cause it to pull, from the inside out. So subinvolution, that word's on your slide, that's just failure to return to that pre-pregnant size. It's not doing what it's supposed to. It can be caused by, late postpartum hemorrhage can be caused by hematomas. That's why we check the vaginal area. Hematomas are caused by injury to blood vessels, maybe from trauma. And each hematoma could even contain up to 250 to 500 mils of blood. So that's why we watch for hematomas and we put ice on it if we see one, right? And we report it. They may need oxygen, just like in all our scenarios where we're treating our patient, we're putting them on oxygen. It's not going to hurt them to put them on some oxygen. They need telemetry. We need to really monitor their heart rate and live them closely. And then fluids and transfusion. Of course, they're going to need natural. They need to know what all their levels are. Major causes on the slide that we've already talked about. So with our nursing interventions, we're going to assess for the presence of anxiety or apprehension, restlessness, disorientation. All those things that tell us that they're not perfusing, or that they may be hypovolemic or hemorrhaging. We need to check our vitals, including our pulse ox, our urinary output. We're watching for shock. So signs and symptoms of shock: weak, rapid, irregular pulse, pallor, cool, moist skin. They may have severe pain or feelings of pressure. Then more interventions: O2 non-rebreather face mask, 10 to 12 liters to maintain oxygen saturation. Our labs would include hemoglobin, hematocrit, platelet counts, coagulation profiles. So blood clotting, because remember DIC, widespread clotting and bleeding. So we would maybe do the PT-PTT to see how long it's taking that blood to clot. So that's a coagulation profile. And then we're going to be doing frequent unknowable kid checks every 15 for the first hour for hospital protocol. They need to weigh the pads if there's excessive bleeding. What would you consider excessive?
A pad an hour?
1 pad an hour, greater than 1 pad an hour. So we might need to test that if we know that 1 mil equals 1 gram. We weigh those, and we know what our pathway is dry, we're going to know what the blood loss is, right? There's a sign in the bathroom at BASS, in their postpart or the L&D, whatever bathroom, that says measure blood loss at every birth. I see that every time I sit down to use the restroom. Must measure blood loss at every birth. They want to know exactly what their blood loss is, so they have to measure it every birth. So, very important. So be aware of our clients are at risk, that need more frequent assessments. Excessive bleeding, massage fundus, make sure you maintain IV. If they don't have one, we may need to start one. Teach and chart and stay ahead. If blood is needed, you need to ask for help, right? You're going to need somebody to check off your blood with you. Continuous evaluation, and know your drugs that assist with postpartum hemorrhage. Know what common medications you're going to use. What do we expect our medications to do? Has the bleeding slowed down or stopped? Is the mother thermodynamically stable? Is there any safety issues we need to look at? So know your medications, like your Pitocin and your Metrogen. Methorganol maleate is the generic. Your Hemabate, which is know what those are and know if they're working. make them have diarrhea. It's common. So you can tell your patient, hey, yeah, it's common, I'm sorry, you know, we'll clean you up or whatever, but, so you know, that's just gonna hinder babies. So then if we talk about thromboembolic disease, this is the last thing that we're going to talk about. So thromboembolic, defined as either superficial venous thrombosis, deep venous thrombosis, or pulmonary embolism. Well, we can have pulmonary embolism after having a baby. There's been a decrease in this though due to early ambulation now, for getting our patients up. You know, back in the day, again, they used to lay in bed for days on end after having a baby. So that would put them at an increased risk for DVT or pulmonary embolism, right? Now we're getting them up and moving as soon as their legs are under them and, you know, encouraging them to get up and pee every 2 to 3 hours and move and drink and do everything they need to do. So luckily we've learned and we're progressing, right, in our research. So incidence is 1 in 1,000 women. So your risk factors, smoker, we know why, right? Mr. Explain why. Obesity, grand multigravida, many babies, many pregnancies. Advanced maternal age is a risk factor. And then some of our comorbidities would be preeclampsia and sepsis. So with our superficial, you know, we're going to see pain and tenderness in the lower extremity. Our deep vein, maybe unilateral leg pain, calf tenderness and warmth. But if we're talking acute pulmonary, we're going to have tachycardia, apprehension, cough, maybe hemoptysis, pleuritic chest pain, dyspnea, you know, impending doom kind of thing. So of course, we're going to do some non-invasive Doppler ultrasound for the DVTs. They may do some labs like a D-dimer. Most accurate is venography. This is an invasive procedure that is associated with serious complications, so it's contraindicated. So non-invasive Doppler, we're going to look at our signs and symptoms, right? Redness, swelling, impending doom, difficulty breathing. So our nursing interventions could include analgesics, rest, elevation, maybe some SCD devices or TED hose on their legs. We want them to avoid prolonged standing or leg crossing. Maybe encourage them to put their feet up when they're sitting down to elevate their legs. So there's that client teaching again. We're going to teach them signs and symptoms and what to do to avoid getting DVT. Any questions? We have a little time, so we'll do a little question and answering here.
So our in-class assignment the one on SurePath, or do we have like an attendance for today?
That's your attendance, is your sure path, and putting it on there that you're done when you're done. So, that's it. All right, so, let's talk a little bit. Hang on. All right, so, I want you guys to teach me some things. So, Tonkawa, what did I say about it? What can you teach me about vaginal bleeding and uterine pain? That's okay, I'm waiting. Speak up. so we're checking our load here, right? See which room or whatever, we're checking our firmness, our pads, greater than 1 pad an hour. Yeah, those kind of things, okay. Enid, tell me types of pain, normal postpartum, and what we do about it. Pain management. What?
The cramping.
Cramping after pains, yeah.
And
Swelling in the perineal area, yeah. Maybe the lacerations. Okay, what other types of pain? What other types? Yeah, C-section, incisional pain. So what are we doing for those things? Tuxedonoplast, ibuprofen, narcotic, expressing clots sometimes helps, right? Yes, okay. All right, Stillwater, tell me about breastfeeding and breast care. So if you're breastfeeding or not breastfeeding, tell me some things about that.
I know if you're not breastfeeding, you wanna encourage them not to pump.
Right,
I'm on Zoom today, but I'm usually in Stillwater.
that's cool. So it's what, supply and demand, right? So anything you pump or breastfeed off, your body's saying, okay, I need to make some more, right? So, yeah, what else? Yeah, fresh cabbage leaves, if they get nourishment, yeah, absolutely. Do they need to let their ladies hang loose, so to speak? Or do they need a well-fitting supportive bra? Yeah, right? Lots of support, cabbage leaves, analgesics. Don't pump, don't breastfeed if you don't plan on breastfeeding. Okay. Zoomer, give me a zoomer for what about elimination of bladder and bowel? Tell me some things about that. You're going to teach your patient.
Urinate every 2 hours.
Yeah.
Perinatal care.
With it,
Yeah.
every bathroom visit.
Mm-hmm.
The use of stool softeners.
Yes.
Increase fluid intake.
Uh-huh. Yes, good answer. So, Tonkawa, again, it's your turn. Speak up about nutritional needs.
They're gonna need an extra 300 or so calories.
Yeah, if they're breastfeeding, they need extra calories. What about for like wound healing and stuff?
Zinc and vitamin C.
Protein.
Protein, your vitamins are good too, right? So they probably need to continue taking those prenatal vitamins, right? And getting good nutrition. So Enid, what about, tell me some things about postpartum infection. Key signs and symptoms, is that what you said?
Yeah.
And then odor, temperature. What about with endometritis, what else are you gonna see? Abdominal pain, so abdominal pain, foul smelling, fever, what is it? Probably endometritis, right? Infection of the uterine lining, so what other kind of infections can we see?
Mastitis.
Huh?
Mastitis.
Mastitis,
And tell them to, if it's okay with the physician, to keep feeding.
Yeah.
Keep breastfeeding.
keep that duct open as much as possible. Don't stop breastfeeding unless it becomes an abscess. And it's, the provider's gonna tell them whether or not. But, it's not an absolute, do not breastfeed on that side, stop right now thing. It's the scenario, it depends on the situation, the severity of the infection, and all that. And they just wanna at least pump, right? Because you gotta keep that duct open, so. So then, Stillwater, tell me a little bit about C-section care. Does it differ from regular postpartum care? I think we're, no, they're still there.
Monitor the incision.
Yeah, we're gonna monitor our incision, right?
Respiratory hygiene.
Yeah, it's major surgery, right? So, What else are we monitoring closely besides the respiratory and the incision? What are we listening for? Vowel sounds, right? Because even if they start them off on clear liquids, if they don't have any vowel sounds, you're probably not gonna give them clear liquids, right? You don't wanna feed them until you're sure that those bowels are working. Do you think C-sections have an increased risk for pain, and why? Yeah, plus, what else builds up in there? Gas. Sometimes the gas pain is what's the most painful for them. That's what really is hard to get under control, so. Okay, Zoomers, postpartum hemorrhage is your topic. Tell me some things about postpartum hemorrhage.
You need to watch for it often.
Yeah, that's good. What are some
It can be
pre-exposure?
early or late, so it can, start immediately, 24 hours, or up to 6 to 12
Yeah, it
weeks.
can occur at any time, right? So what puts them at high risk for postpartum hemorrhage?
Short
Having longer
labor.
babies.
Yeah, large babies.
Long labor.
Somebody said a long labor.
Longer labor, yes.
Using instruments during labor.
Yeah, instrument. Yeah. And then, of course, you know, your,
Retained placenta.
yeah, there you go, that's what I went for. Okay, so then, the last thing I have on my list is contraception / sexual activity. Just anybody tell me about that.
Breastfeeding's not a contraceptive.
Breastfeeding's not a contraceptive.
No intercourse until at least 6 weeks.
Okay.
We got time for that.
Ain't nobody got time for that, that's right.
And, progesterone only.
Yeah, just an only, not the estrogen, okay? Yep, alrighty, I guess I'm finished. You have until Saturday at 9 AM to do that.